So welcome today. This is Raman Sharma from Mount Sinai. We welcome you to a little unique hybrid live session of our endovascular live case from Mount Sinai Booster Heart Hospital in New York City. And, as we like to end the year with a bang, we like to do some pretty complicated stuff. So, apologize for any of AV issues. That kind of gives a much delayed start than usual.
Oh, yeah, definitely.
But let's jump right into this. PK, I see you already working. So why don't you tell us about what's going on in this patient we have on the table today?
So very, very interesting case, Raman. It's a gentleman with rest strain, but we'll go ahead to David to go ahead and present.
Good morning, everyone.
I have the micro.
Our patient is a 60-year-old gentleman referred for lifestyle lemon claudication, progressive to ischemic wrist pain, right greater than left, Rutherford Grade II, Category 4. The patient has known PAD, has had multiple recent interventions of the left SFA and anterior tibial artery, hypertensive, and hyperlipidemia. He currently still continues to smoke. He is on good medical therapy with aspirin, Plavix, Crestor, and Losartan. We have previous angiogram. In terms of the left runoff, we fixed a left SFA and left ATA before. In terms of the right, we have an osteo right SFA CTO occlusion with a small nub, and it reconstitutes in the mid-distal SFA region. And we have one vessel runoff to the foot.
So Raman, when we got access, maybe Vishal can go over what happened.
Yeah, so we're gonna show you some picture. So we got a left axis, and hold on.
So right off the bat, I think we haven't had a case like this in a while. Usually recently we're doing some more like localized CTO lesions. So let's take a step back. So what size French did you guys choose for this? I asked that just because of the fact that the amount of work it seems that we may be ending up doing.
Yeah, so we went with the 7 French, but I think you need to see what happened. And then we'll talk.
This is
so look at this.
I already like the sound of it.
Well, I don't know about that. Hold on, so I'm just make sure I confirm my position.
So you see a needle somewhere where it usually isn't.
Well, that's a wire introducer. Go ahead.
So you can look at the picture, which is like David talked about having a previous interventions. And this is the left axis. The femoral artery looks good. The stent looks gray. But this is where the problem happened. So if you can see Raman, you can see that there's a staining right there at the aortic level. And you can, if you look closely, we took a DSA shot. Let me see if I can play the DSA. That's the DSA shot. So if we look at the DSA shot clearly, as compared to the previous pictures we had the privilege of having, we didn't have that issue. But here you can look, the catheter is actually in the aortic ulcer, and it's actually slightly outside the main aortic vessel. So you can see it's deflecting or deviating itself into the ulcer, which probably also has this overlying thrombus on it. And that's where we injected, because not knowing how it was.
Well, we had good pressure, right? So we injected.
Correct. So after this, you can see there's double density. We did some dry stain, and there was actually a hanging dye stain there, which was a little bit concerning. And then PK, did the measurements. The pressure was good.
So let me talk a little bit about this, Raman. So we called Dr. Rao, who is our vascular surgeon here, and along with multiple others. And Ajit, actually, we FaceTimed him, showed him this. Patient is stable, so we decided to go ahead with this. So Dr. Rao is here. I'm going to mic him up and just talk a little bit about the natural history of this, what we should do, what we shouldn't do, and then we'll talk a little bit about this. So maybe you can just get a microphone on Dr. Rao, and he can just come in and just talk about it.
Yeah. So I'm curious. So in the previous angiogram, how exactly did that distal aortic bifurcation look?
It was ectatic, but it was not any clear aneurysm or ulcer angiographically. And as you know, we don't do axial imaging on these cases unless we're suspecting any aneurysm. And the patient had an ultrasound about 3.5 months ago, which showed, just ectasia of the aorta. So he had a penetrating ulcer,
like
obviously.
2 or 3 centimeters absolute maximum. Yeah.
Right.
But this is a pretty interesting. I mean, this is a pretty pronounced, ulcerated margins here.
Right. So
makes you wonder
Ajit
kind
is
of
here.
what's the etiology.
So Dr. Rao was kind enough to just come in and take a look. So I'm just having him come in just to talk to us about this aneurysm and what he thinks we should do.
Yep. Can you guys hear me?
Yes.
Okay, I can also hear myself. I'm getting a little echo.
Yeah, it's not going to go away.
Okay. So, it looks like there's an ulcer there. It's hard to say without a CAT scan unless we IVIS or something how big it is. But it's pretty common with ulcers or even a small aneurysm versus like a penetrating aortic ulcer that there's some thrombus there. So it's probably some chronic thrombus in there, and it's kind of maybe looped around in the ulcer. So unlike AAAs, which we have like great data on, there's multiple randomized control trials showing, when we fix them, and which is typically 5.5. For PAUs, penetrating aortic ulcers, the data is much more limited, and so the guidelines are still to treat them in a smaller size because we think potentially they could rupture, but there's no like randomized control trial on it. So probably for this one, I don't think it's an emergency or anything. I'd probably just get a CAT scan post-op, and then based on that, decide if it needs to be fixed.
So Ajit, a couple of things. I want you to look at the aorta now. See, the dye seems to have spread around the aorta, and also has come to the right side a little bit as well. Yeah. We had a little bit of trouble getting up and over in terms of meaning the wire finding the true lumen, I guess, for lack of a better word. And then when we went up and over, the pressures are fine. Everything is fine.
Yeah. So I don't think. It obviously looks very concerning when you see the contrast doesn't wash out. But I do think it's probably contrast that's within the thrombus of the ulcer. That being said, on the way out, we should take like another picture and just make sure everything's okay.
And would you do an IVIS?
I think if it didn't look like perfect or we're concerned, then definitely IVIS. But I think you'll get most of the information from just the angio on the way out.
Okay, perfect. Yeah. So then we can go ahead and fix the SFA.
Yeah. If the pressure is stable and it looks like it's in the thrombus, I think it's fine to proceed and just shoot it on the way out.
Okay. And what are the things that you look for that are concerning on the way out?
So if you see that you compare it to the initial and it looks like there's more of an outpouching, or you're seeing any sort of contrast that's not washing out when you're definitely in the lumen, or there's like a pressure drop or things like that. Those are the things I look for. And then also the other important thing is to make sure there's no thrombus that may have embolized into the hypos. So something, you just take some good pictures on the way out.
Wonderful. So I guess in this case, we're going to go ahead and fix it, a long segment SFA occlusion, and then we'll go ahead and take care of it. So we'll show you the angio, what we've got. I'm curious, since we have you here. I know you got to go, but before you go, how would you deal with it? So here's forgive the echo, it's really annoying. So here's the SFA occlusion, little nub, but I can tell you when we crossed it offline because we were having AV issues, it was a very difficult cross. So we were able to get across and get through the distal level.
Is the patient's a claudican?
He's a true claudican, yeah.
With respite.
And he's got, let me show you the vessel runoff here. He's got single vessel to the foot via the anterior tibial artery. And the PT comes back. I think it's a poor picture. We'll take a better picture. But it looks like single vessel for now. So this is what we did. So we went with a vertip catheter and an angle glide, tried to find the ostium, I guess. And then we were able to poke through. You can see here with a lot of difficulty, a lot of fibrosis. in this, and this groin has not been intervened on before, or this SFA. And then we switched out to an 018 Mongo wire because the 035 wire was not going well, and we were able to track it to this level. Then the Mongo, we got subintimal at this level, and then re-entered at that level. So we just went with the Mongo, got through, and then we checked our position here. So now we're going to do a quick IVIS, and then we're going to decide what to do. And I'm curious on your thoughts before you. I know you got cases today.
Yeah.
So let me just show you a
for
quick
sure.
IVIS.
You said that the wire was subintimal.
Yes.
Yeah. So I'd be, I mean, I definitely IVIS, see how, what plane you're exactly in, but I'd be hesitant to be aggressive about atherectomy if you're subintimal, and probably it'd be, DCB and spot setting is potentially one option.
Are you worried about aneurysm formation at JIT, or why are you worried? Wow, it's not going. Ray, what's the sheet?
I mean, I've definitely have atherectomized in subintimal planes, but you have to be careful because I think directional atherectomy is
Okay, let's start here.
Is a good option, but you could potentially disrupt the wall of the vessel and cause a rupture.
Yeah.
Yeah.
You can see
So
here.
it was really
pulling
important to
back.
kind of see which way the cutter is actually facing in those segments. I think it's a very, very smart point to make. I did one more question for you. If you were to have seen that this SFA CTO was one that was just incredibly calcified, one that you would assume would just almost cause some degree of like sheath movement, like a lot of aggressive sheath movement back and forth, would that kind of change the order in which you would be taking care of this, where you would say that I'm going to actually rather fix the distal aorta first, just out of like safety to that penetrating ulcer?
Yeah.
Like having trouble tracking the sheath, you said?
Yeah, but does you feel as if there's gonna be just like a lot of like sheath migration because of just like a lot of like just like very a very densely calcified CTO lesion that would require like a lot of pushing and pulling and stuff like that.
Yeah, if I think there was a iliac stenosis, I would fix the inflow first. But if it's just calcified but no stenosis with that aneurysm or PAU, I'd be very careful. I probably wouldn't push it, especially for claudication.
Yeah.
So can we play the IVIS, and when Vishal can comment on the IVIS?
So here, if you see the IVIS, we start distally and put it proximally. So distally, you can see a segment we actually entered. We are intraluminal. So if you look at the whole segment, we're in and out. But here you can see we're intraluminal. And there are segments in there we actually go subintimal and come out. But most part of it would intraluminal to begin with. So here you're still intraluminal right there. But now we go subintimal. You can see the plane almost compressed at between 6 and 7. And now we come back intraluminal. So it's just in and out, like Pika's talking about, and the way the wire was behaving pretty much corroborates with your movement of the vessel and the IVIS in this case. And a lot of tissue, not much calcification, surprisingly, which even angiographically is not that visible.
Very fibrous.
Yeah, it's all fibrotic component. And here again, we're intraluminal back in. And then proximally, we have good lumen and a good landing zone for at the nut. So here again, we were extra, and now we're back to intraluminal back again. So again, when we do CTO, then PK and everybody and Raman and Ajit know that you can go in and out, which probably is there. But I think the most important thing is not much calcification. And here, see nicely intraluminal, even though in the SFA CTO segment, the lumen is still there, and we go extra.
So I guess the reason we presented this case was to talk about the contemporary management of long segment SFA CTOs. I mean, there's multiple studies that have now been published comparing DCB to DES. I mean, best SFA, the sports trial, which we were supposed to present today, but I won't comment. But the idea would be is what is now the contemporary management? So as you know, guys, best SFA showed no difference between paclitaxel coated stent and paclitaxel coated balloon at 1 year at a cost of a 25% provisional stent rate. At 2 years, even though it's not been published, it was presented, there seemed to be a divergence of the curve with the stenting, showing stenting may be superior in terms of TLR rates and patency rates. In the sports study, where they looked at paclitaxel coated balloon versus paclitaxel coated stent, specifically the Boston stent, versus drug-coated balloon with bare metal stenting. They found that drug-coated stent was superior in reduction of TLR in these patients. So now having said that, now the utility of IVIS telling us what we're going to do. What do you think is the best way to vessel prep and the best final therapy? Start with Ajit.
Yeah, no, I think those are all great points. I think it depends where you're treating, so if you're in the popliteal artery, that's not an area you want to stent. So that's where I'd be more aggressive with a DCB. I think one of the reasons potentially that you may have an earlier failure with DCB is you accept a suboptimal result because you think there's drug there and it's going to protect you, and that potentially may not be the case. So I think you need to get a good angiographic and IVIS result. I think in this, it's a above knee SFA, so I'd be more inclined to stent, because I don't think I can do a bypass that above knee pop anyway, because it looks like it comes back pretty low. So I'm not losing any bridges, we're not losing any if we stent all the way down. So I think it's reasonable to stent, and you could, if you weren't going to stent, then I think based on that IVIS, atherectomy, directional atherectomy, probably okay, because I don't think you're so close to the wall where you're going to perforate or cause any issues. And then, DCB and spot stent. But I think here I'd be aggressive about potentially putting in stents and getting a good angiographic result.
Yeah. No, I think I agree with Ajit. I mean, in this case, the good thing is we have great IVIS imaging to really direct us. And like Ajit was talking about, the failure of DCB is because we never tried to size it appropriate. And initial trials show that if you don't size it 1.1 to 1, the restenosis, the TLR actually goes up. So in this case, agreeing with Ajit, I'll also do aggressive atherectomy directional because we are pretty much in there and not much calcification. And then line it with the DCB. And then if there is any flow limiting dissection, maybe stent focally if you have to. But I think
Raman, any thoughts?
Yeah, I mean, I think Ajit, you brought up a really interesting point about the previously accepted dogma of saying that an angiographically okay result is actually sufficient. And I think as our technology is kind of being more thoroughly investigated, and we're seeing that what the long-term outcomes are of people who have now really chosen the drug-coated technology, whether it's balloon or stent, I think this dogma has to kind of be revisited. I think it's a really interesting idea to see what exactly is an acceptable angiographic result or IVIS-related result. Unfortunately, the data is still not really there to really say which one of those two is actually probably the more correct, if either is really correct. But I do agree that I think that this is in a safe area. It's a low flexion point. I think considering the amount of time you spent subintimal, intimal, I think PTA and a long DES should be enough, to give a very favorable outcome for this patient, all things considered.
Well, there is more and more data talking about why we fail. Obviously, our paper here in JACC talking about residual stenosis. But the funny thing is, I was in JET 2 weeks ago, and there's a paper out of Japan that looked at DES failure, and also 30% was the number. So I think that's why vessel prep is showing more and more as the appropriate way to do it. And the question is, what is the best vessel prep? If we're going to stent anyway, do we save money and just do a large balloon angioplasty, expand the lesion and put a drug-coated stent? Or do we need to atherectomize? Definitive AR, as you know, showed some benefit in calcified long lesions, a very small number of patients in the directional atherectomy arm. So to me, that's now the controversy. What is the appropriate vessel prep? Is it balloon angioplasty? Is it cutting balloon angioplasty? Is it a directional atherectomy? Or is it just I guess those are the three.
Yeah. Is this if you're going to stent regardless at the end?
Well, if you believe sports and if you believe best SFA, and you're saying that stenting may be now starting to show superior in real world lesions, then yeah.
Because I would say if you're not going to stent, if you're not committed, then atherectomy, there is some data that it decreases your rate of stenting, and then it makes perfect sense. I think if you're going to stent regardless, then I think it depends on the lesion, like you said, how calcified it is, how based on the IVIS, how much plaque is on the vessel, if it's diffusely diseased. But I think we need more data on that.
So in this case, not calcified, long segment. Subintimal, intimal, you're going to need stenting.
Yeah.
I mean, do you say bite the bullet, let's just balloon angioplasty and stent this? Or do you say, no, let's directional atherectomize and spot stent it?
Yeah. I think because it's a above knee SFA and it's not too calcified, so I think the balloon is going to open it up. I think you can make an argument to just treat it, prep it with a balloon and stent. I don't think atherectomy. I don't know how much it's going to impact.
Anything?
Yeah, I don't know how much it's going to add for this sort of lesion. Yeah.
Well, I guess it's an open conversation. Like PK quite correctly said, there's not enough data to say one versus the other. So if I say something, I could hold the same water as you do. But like for me personally, I would not want to do a whole, because we know the longer stent we use, the chances of ISR go up, even though it might be drug-eluting, drug-coated stents. But in this case, for my personally, like based on my clinical decision making, I would probably be aggressive in atherectomy, DCB the whole line, and then probably do a spot stenting, hoping that I just save as much metal. I don't have to put anything.
And I think it also depends what your risk of atherectomy here is. Here you have good runoff.
Correct.
It's above knee SFA, so I think the risk of atherectomy is low.
Raman, what do you think?
I mean, this is a it's a really good debate. And I'm curious to know which way we're going to end at the end, but I think, I'm always kind of reminded of kind of how we do things in the coronary world. Granted, it's a very different landscape. We have, the atherectomy devices that we have are dedicated for highly calcific lesions. The idea of debulking, plaque modification for highly calcific lesions has already been demonstrated to show a great, improvement in overall outcomes. But for just fibrotic disease and the high atherosclerotic plaque burden, there's no real atherectomy device that we really use anymore. Really, it's just different types of scoring balloons, cutting balloons, and different atherotomy devices. Yeah, exactly. And I wonder if at some point, is that same mentality also going to hold true for the infrapopliteal and infrainguinal disease? I think this historically myself, I would have actually done this pretty similarly, before all these past couple trials have come out, probably very similar to how Vishal had actually mentioned, just but focused directional atherectomy, making sure we try to stay away from the abluminal surface and try to space as mostly interluminally as possible, considering that we've seen how the wire actually went. And then just go with a well-sized DCB, and then just line it with a Supera wherever it may be needed proximally, and probably would end up putting a drug-coated stent, but just kind of to mark the ostium. But I think now the argument is is that really the right way? Like, what is the that's the question. Like, what's the vessel prep? And I think there's still some more work to be done to figure that out.
I think for this lesion, if you're aggressive about atherectomy and then size the balloon with IVIS and appropriately, I think you're going to get a good angiographic result. I think it's going to expand up.
All right, let's give a directional atherectomy. And what's the size of our balloon?
You want LX or
M? LX.
LX.
So your top measurement is 5.5.
Oh wait, you guys are going to go with an LX, not an M in a situation.
Yeah, we're going with the larger because we're going to have to do more cutting.
Oh, good. So then really have to be making sure that you're facing the right way.
Right, exactly. So the question is, how do you size the balloon? You heard the size of the vessel.
Yeah, it was 5 to 6, right?
Right. Well, would you say when again?
5.5.
5.5 to 30 when it opens, and all the way to a 6 approximately, and 4 during the CTO.
So, I mean, it sounds like most of it's 5 to 6. So I'd probably do a 6 DCB and not go very high, especially distally.
So you just go 6 long.
Yeah.
And distal protection, yes or no? We didn't use
for atherectomy.
Yeah.
It's 3 vessel runoff.
No, 2 vessel. Well, we didn't put it in, so we're going with that.
Okay.
Oh, wow.
No, I think it's reasonable. It's not 1 vessel runoff. It's above knee lesion. So
I think we make shorter cuts.
Just frequent packing and all that.
Packing, yeah. So, okay, we're gonna go with that.
I mean, I'm actually to be totally honest.
I'm sorry.
Given so my actual concern would actually be less with the atherectomy, because the technique of that is something that can mitigate like a thromboembolic risk. Yeah. But the DCB and the PTA, that's what I'm actually more concerned of, and then what that's going to do to the distal embolization. It's a very long.
What do you think atherectomy is not, but PTA is?
Well, because you're tooth spacing this plaque somewhere. You're not going to be catching all the actual plaque with the atherectomy. I mean, unless you're extremely very well focused. And plus,
Off.
the
Off. Okay,
previous
very good.
ideas of the paclitaxel from the actual coating of the balloon can actually result in more distal embolization. All these things put into consideration. But the long lesion, non-calcified,
Careful.
mostly
Yeah,
atherosclerotic plaque with some fibrous
Mark,
disease.
yeah.
Yeah, I think the quality of the plaque matters too, right? With embolization, like if you have a soft plaque, that potentially could flick off a little easier. If you have a lot of calcium and you're pushing aggressively on the atherectomy, then you're probably gonna be at an increased risk of embolizing. So I think all that matters as well.
Yeah.
And I think definitely with this case, I wouldn't be aggressive about if trying to track the atherectomy. If it's not going, stenting,
Yeah, call it a day. Yeah.
call it a day. Don't embolize, especially claudication, rest pain without a wound.
Well, that's why we have you, so we can say, Ajit, help us out here.
Now, I think David's eyes are going to light up when I say this, but what about PQ
No.
bypass?
Yeah. Well,
So-
is it going to be a first line for you? That's the question, right?
So I was thinking about it. I think for this lesion, no. But if you had a very calcified,
10.
tough
Can I go to
SFA,
loud needle
and you
time?
think you're not going to cross easily, and you're going to embolize, and maybe you think, spend 3-4 hours trying to do that case,
Come down.
I think you can make an argument
one more
to go with
One more
primary
pass,
PQ
loud.
bypass because you have good targets, and you decrease risk of embolization, especially in CLI. I think that's an option.
So you think
everybody-
embolization is such a big deal in terms of these long segment SFA lesions off?
Well,
On?
embolization or suboptimal result. Like if I'm talking about severe calcium where even the stents may not fully open.
I'll make it rotate it.
We have
Lateral?
shockwave now and things like that to decrease the chance of that. But I think it's a consideration.
I
you know,
agree.
You do a PQ bypass quicker than trying to treat a tough SFA, calcified CTO, and probably with lower risk.
We've got one today, later today. So
But do you foresee
on.
even do you foresee yourself, for anybody in the room, opting for a PQ bypass for even this densely calcified proximate distal SFA CTO segment lesion without even attempting antegrade
Careful, don't wrap it.
recanalization? Do you think that that's ever going to find its way into your practice? Say, this lesion, I'm not even going to bother trying. We're just going to go straight up front with the PQ bypass.
Yeah, no prior endovascular interventions.
None. First time.
I think
First time come up.
I think that will.
Not bad.
Yeah.
Maybe fist level.
All right. The question is, should we make more passes now, or just go ahead and balloon it? It's definitely not an optimal atherectomy result right now.
I'd probably just balloon at this point.
And what balloon would you use?
Probably a 5 or a 6.
Would you use a cutting balloon
6.
or a regular, just a high pressure Dorado?
I think it would open up with a high pressure Dorado.
So give us a Dorado 6.0.
But to answer your question, I'm not sure that will be widely accepted. I think we need data for that. But I think if it failed endovascular, interventions twice in a short period of time, then I think PQ bypass is definitely a reasonable option.
Yeah, I agree with that. I think even like I just did one on Monday, spent about 2.5, 3 hours crossing. I mean, it was work. I had to go from a 1.0 balloon to a 1.5 to a 2.0 to eventually pave the way for everything. But it's the end. Assuming we use all of our adjunctive therapy like IVL, which is a big game changer for these density 360 degrees calcific lesions. You can still have a favorable result, and I think that this PQ bypass, although it's sexy, it's an interesting idea. I think its niche is going to be for, as you said, failed multiple endovascular interventions. The question, though, would you also do PQ bypass? Let's say you've had 2 different rounds of BCBs, but no stenting. Would you first try to go as your next, attempt at recanalizing this lesion if there was no metal in the previous attempt?
Yeah, that's a good question.
And all it was,
I think if
it's just CCB.
like early recoil and it's not a bad area to stent, then I think I might try stenting first before I go to PQ bypass. And the other thing is you can even with stents and the SFA, for that proximal anastomosis that you make with the PPU bypass,
heart rate,
you
Liz?
can do it through stents too, so it doesn't burn that bridge.
Yeah. Exactly.
Yeah,
TK, what about
and
you?
we've done that live. Ajit, all three
Yeah.
of us, all four of us have done it live with Karthik. Yep. Go to 12. So this is the vessel prep. You can see we're at 12 atmospheres with a Kevlar balloon. So well
This is a
expanded.
5 or a 6?
Is this
Six
It looks like a 6.
Yep. So I'm just
And
gonna
with
leave it
no
up for a
distal
minute.
protection, correct?
so?
So far.
So after this, would you take a picture and then decide whether to DCB or stent?
Well,
Or
I
is that
think
your
we're
algorithm?
going to go down the path of DCB. You know, I think the group, you know, because there is data, but not convincing yet, that looks at that said the stent is better. So we're just going to go with DCB here.
I mean, 3 years ago, that would be my algorithm always. You know, atherectomy, DCB, spot stent.
I have definitely changed. I'm definitely studying a lot more based on the data that's now available. So studying a lot more. A little die here. Let's check the osteum. Yep, go up. What is it? All right, give another 1,000, please.
If you were to elect to do the DCB the destination therapy, polling the room
14,
here,
16,
who would
18.
DCB only even that osteal lesion, as opposed to DCBing the distal prox and mid segment and DES proximally, as opposed to DCB the entire length?
I think if you look at all the impact long data, if you look at even best SFA with DCB, there's always a 20, 25, 40% stent rate in these complex lesions. And so I think it's hard to just leave it with DCB only. That's why I'm thinking cut to the chase, put the stent in, be done. We know that Supera is a bare metal, and if you look at the sports trial, which did not study Supera, you can't say that Supera plus DCB would not equal a DES. We have our studies here out of Sinai. We looked at 500 patients, which was published just last year, which looked at DCB prep followed by Supera, which mitigated the restenotic effect of elongation of the Supera. So there is some data with Supera with DCB. However, it's not head-to-head with DES. Yeah?
Sounds like a great investigator-driven study, in my opinion.
I like that idea. Let's do it.
Yeah, I'm all for it. But I meant specifically for a particular location of disease, and I meant at the ostium of that SFA. What would be your destination therapy for that focal area?
No, I agree with Raman. We just usually stent the proxipart with the DAS, make sure the inflow is not compromised. And then, of course, DCB, the whole segment, or if you stent, depending on what the lesion looks.
Yeah, I agree. I'd be more willing to stent proximally than distally.
Wow.
No.
Bit of recoil.
It looks as though there's no embolization, which is, comforting.
So if you think spot stent,
no,
that's an area that looks pretty bad. And then here's, or just DCB and leave it.
Well, I think this is a great lesion for it because it's not perfect, Okay. So if you DCB, there is a chance, you could be leaving 30% residual stenosis. So I think you could, if you were still adamant about not stenting, you could IVIS.
Let's IVIS.
And I'm sure it's going to look worse on IVIS because it always does. And then we'll probably end up stenting.
Let's IVIS.
But
we have the IVIS here.
But I think these are the cases where just doing DCB, not stenting, is where you could get potentially an early failure with recoil.
So where would you stent though?
Yeah.
That's the question, right?
Well, so this is where you could spot stent. So that one area in the middle that you were talking about.
And the osteum.
Yeah.
And the osteum.
And the rest you would DCB.
Yeah, so I think that would be reasonable.
So would you DCB the whole thing and Supera spot stent that mid lesion? Or would you just go with a Zilver or the Illuvia?
Yeah, I think if IVIS looks pretty good, I would just spot stent. Okay. And then...
Ready? Put it up. There it is. I see it.
Hey, oof, dissection.
Nasty.
Yeah, that's the cutting atherectomy. It gives you the dissection.
A lot of plaque, guys.
Oh, just dented.
Hopefully it's not on the foot.
No, it's not. Thanks for the morbid thought.
That's called
Okay.
optimism or realism.
I mean, a lot of plaque, but good
Yeah.
lumen. See, it's that mid segment, but even here,
Yeah.
look at that.
Like I just said, it looks worse on the IVIS as compared to the angiogram.
So
But it's a real picture.
I guess we'll do our own experiment here. And there's your ostium. Not yet. Right there. So yeah. Okay.
Yeah, based off IVIS, that ostium 100%, I would
Yes.
stent. That's not even a question.
And even the mid portion.
And the rest of
mid
it?
portion.
All
I
right,
mean,
well,
to be honest, like
I guess.
I think, yeah.
Oh, go
How
ahead.
did you?
Sorry.
You go first.
I think I would potentially spot stent and then DCB the rest, because I think in this case you can save a lot of, rather than creating a full metal jacket all the way down, you could do two short stents.
So do we have a
But-
long 7.0 DCB?
But I don't think you'd be
7.
wrong, because it's definitely residual disease in some areas, 20-30% on IVIS. So I don't think you'd be wrong to consider stenting more.
Yeah, I think that's what I was looking at. If you look at the angiogram technique, I would want to stent from 10 going all the way back to 0, and then have to stent at the ostium. So the only real non-stented DCB part is just maybe like 100. So the question is, you leave a gap between two stents, and then becomes an issue down the lane versus just stent the whole thing, or just to stent, add another 10 and you stent the whole thing.
Right, and then the other question is cost, and then also drug-coated balloon bare metal stent, I assume, versus drug-eluting stent all the way down. So
that's why we presented this case.
yeah.
See, it's not so much technically a difficult case, but decision making is a big thing now.
Right.
So that's the thought. So that's
Yeah,
why we have Alluvia.
There are 4 of us here.
We have Alluvia, we have Supera, we have DCB, we have everything here. So the question is, do we just do a DS?
Yeah.
So we have 1 vote for DS.
I'll DS.
I'm still going to be old-fashioned and say DCB and
one
spot
with
sitting.
1. Raman, you're the tiebreaker.
Yeah. No, so
No pressure.
I would do 1 long DCB.
DCB.
It's pair of the mid and
Okay.
the DES.
So DCB wins. So give us the longest DCB you have, 7.0. 7.0, then 6.0.
So the vessel.
Then
yeah,
give us 250.
Because it measured out to be 6, right?
Yeah.
Yeah.
Yep. 6.0, 250. Impact. You got to run?
Just for
Yep.
5 minutes.
You're gonna go. Okay. Dr. Rao is gonna run. So I'm gonna take a picture of the procs, and then I'll give FaceTime you.
Yeah, and I'll be here. I just got to sign the paperwork.
Okay. Please, we can come back.
Yeah.
Be great.
Thank you,
All right.
Ajit.
So
Thank you
Ajit,
very much
so
for joining us, Dr. Rao.
Thank you.
Hopefully he'll come back. He's got to do a timeout, so he'll be right back. So we're just gonna go ahead with the. Whoops.
Oh, yeah, no. Won't go like that. Just with dry gauze. Let me get you dry.
So it sounds as though for this case, we're going to just take care of just this SFA lesion and leave all the tibial stuff alone. Am I getting the right vibe here today?
You 100% are.
Yeah, it's more of a progressive rest pain, but no ulcer or gangrene. So I think improving the inflow with this will really help the patient with the symptom, and then I'm sure he's going to follow up in clinic and then go from there.
Well, we're gonna send it to Dr. Rao.
Oh, okay. Oh, yeah, that's true.
And I wanted to ask him what stent graft would he use? Would it be the Endologics or the Gore, or what would he do? Going up.
See the proximal?
I just want to make sure distal we're covered.
You good?
Probably one that would still preserve the carina, just in case you have to cross again.
I agree.
Yeah. So an AFX would be a pretty good option in this case.
So
especially considering the conversation of re-intervention, so on and so forth. I think keeping this because carina open is actually pretty critical.
go to nominal.
Yeah, 6 is now.
So we're going to nominal here, and we're going to leave it up for 3 minutes. So antiplatelet therapy, antithrombotic therapy, bradycardia. No, not bradycardia. Yes, bradycardia. A little bit.
Yeah, I mean, finally, my drug of choice has made it into the guidelines. So this the gentleman would be on aspirin Xarelto for sure. The 2.5 twice a day. Remind me, there's no other anticoagulation indication with this patient, right?
No.
Yeah, so I would do aspirin and Xarelto. I've kind of started to, like to put people on Plavix for just 1 week or so. Just kind of give them that extra little, antithrombotic, antiplatelet protection. We see that, the bleeding, it really only happens once you take them off for more than 28 days with all three.
Right.
So I think for me, I would put this patient on just aspirin and Xarelto and give them Plavix for just 1 week.
Right. But again, with the DCB, I think that's very like your opinion, because DCB still we need the 3 months.
Yeah, I was gonna say
3 months of antiplatelets.
Yeah.
1 month actually. Excuse me.
I usually put patients on aspirin, Plavix, Xarelto 2.5 for a month, and then go aspirin and Xarelto 2.5 based on their profile.
So approximately, we're going to do an Alluvia. Is that okay with you guys?
Yeah.
So Alluvia 6060 or 6080.
I think we should be
Very interesting case here today. And I think this really does highlight, 4 operators in the room, well, 3 in a room, 1 in a different city, but everyone has a little bit of a different algorithm here.
Well, I hate to say this, I'm the only one data driven.
I think we're all just quoting different data.
It's just what you read in the web.
Whatever, whatever agrees with our opinions more.
Exactly.
I think there's,
right by the dot.
I think there really is some truth to be said about how once we are getting to the final stages of the paclitaxel encoded technologies and we're introducing the sirolimus technologies, the endovascular realm has kind of been dragging behind the coronaries by about 20, 25 years or so as far as the data for vessel prep and imaging and so on and so forth. So it's very likely we may see very similar shifts in the overall landscape of how to best really treat these patients and these lesions. And I think the idea of, as Dr. Rao was saying earlier, what is okay post procedurally? This 30%, is that really okay? If it's not, then what is the marker to decide that this is okay?
6080.
And at what point do we decide to do more? I think with the different atherotomy devices coming out, I think there's an interesting position to be kind of had. Say, let's reformat the way that we talk about vessel prep. There's calcific lesion vessel prep, and there's non-calcific lesion vessel prep.
Yep.
And today we just proved that plain old balloon angioplasty does an excellent job. With
in all the studies, the balloon angioplasty is done really, really well, right?
Yep.
If you look at even Life BTK, if you look at the balloon angioplasty result, and you compare the balloon angioplasty result in the Saval study and put it up against the Life BTK results, I think the outcomes would have been different. So it's very interesting to see the technique of balloon angioplasty and how that has an effect on your results of your studies. So let's see this here. I know you can't compare trials, and I'm going to get shot for saying that, but it's a reality. Go ahead, little die. I'm going to go down a little bit.
I mean, it's a very important differentiation to make. I mean, Saval's Saval
like that?
proved that PTA works.
No, I'm not.
Yeah, then do it. Okay. Give him a little die, David, when he asks.
Yeah, sure.
So we're just going to start.
Just do a roadmap. Hold on.
Let's do a roadmap. I mean, I don't like jail in the profunda.
I agree.
So
yeah, that's good.
There you go.
Okay, 1 second.
Go ahead, brother.
I like to have one strut.
Sure, you want to cover the
outside.
ostium. I agree. Technically, you want
Yeah.
to cover the ostium, no question.
Yeah. That looks
So
perfect.
Dr. Kapoor
Beautiful.
is our expert stent placer.
No pressure.
No pressure. Exactly, right? All right. So, excellent, as always. Walk it out slowly.
Yeah, fantastic.
So now we've done a lot of discussion. So we're going to re-IVIS and take a decision.
You
We're
want
going
to
to
balloon?
re-balloon this, so we're going to balloon this offline,
Yeah, no.
but let's
Okay.
re-IVIS.
Yeah.
So for everybody at home, we're going to re-balloon this stent to expand it properly, but I just want to, for the sake of time, re-IVIS. It's almost 9 o'clock. So I'm just going to do a quick IVIS. Let's do a quick DSA here. See how this looks post-balloon. Hold on. Low mag. Oops, wrong way. Okay, ready?
Ready?
Definitely needs to be fixed.
Yes.
Yeah, look at the recoil, dissection, everything.
And the flow is not the best. So, okay, let's go ahead and re-IVIS right now. We're going up to 15. We know that's where we came back. Okay, ready?
Yeah. Start
Record.
recording. That's all.
The flap there.
That's
How
right,
far? Can we also
right
get the
around
angiogram
14.
side by side, please?
Side by side angiogram. Right there.
Yeah, so it's 15 all the way back.
This, we can probably leave this. Well, I'd leave this.
Yeah.
So just short in the distal. All
Then
right,
we're
give
gonna
us a
enter the
short
stent.
60 Supera. 6080.
Maybe a little bit longer, right? To cover from, like you said, about 14 or so,
15,
14,
yeah,
15 to about
15 back.
like 4.
Is it to 4? No.
No. Say
I don't know.
9.
I think like more like 10.
Wasn't that flap at 5?
No.
No, I don't
From
think it was that high,
the
Roman.
It was 9.
DSA?
No.
It was a 9.
So do we dare look at the runoff?
Yeah. Maybe put a nitro. Nitro.
No, let's not do it
Okay.
right there yet. Let's just inject.
Okay. Good. Nice, robust peritoneum.
Very good.
Yeah.
All right.
Still some work left to do next time should the disease worsen at all, but I think it'll be interesting to see how what the decision will be made for how to exactly repair the distal aortic penetrating ulcer, so as to preserve
Maybe we
any
should do a
future
follow-up,
options
Roman,
for it.
on in July.
Yeah.
6080.
That's fine. All right, rail, full. We want to shout out Karthik here. We miss him. He's busy doing with family stuff, so we'll see him for next July. Right there. All right, Stan.
It's a good job.
All right, so we're gonna place this right here.
So we have a 6-0. Was there some pre-dilatation that was done,
6-0.
or just with the
7.
okay?
We didn't do
Got it.
7, but I think it should be fine. It's the 6 expanded beautifully.
Mm-hmm.
Let it go a little forward if you want. There you go. Now you got it. I think it'll be fine. Even I would have felt confident deploying this. No pressure, Rocha. Ray's rolling his eyes.
I'll say the one thing which I really, really like about Supera is that it may be a relatively, not perfectly elegant deployment. But when these patients come back, a year, 2 years, however so long, no matter how that stent was deployed, it looks perfect.
Yeah.
Afterwards. No matter what happens, this speaks to kind of like the overall delay it may take for it to reach its nominal nominal size. Again, assuming that you've not had massive elongation or stacking. But if you fall within that 10% margin, it really does conform to its a natural shape quite well over time.
All right.
If
So
you
we're now,
infold stay.
we're almost at 80 there. Vishal is going to deploy it here. Beautiful. All right, we'll do a quick IVIS. And actually, we don't need to do an IVIS. I think we're happy here. All right, walk it out, wire out.
Very much so.
Actually, leave the wire in. So we'll just do a quick runoff here. Oh, just do a quick shot here. Okay, good. That's good. We had a offline. We're going to post highlight the 7-0.
Fantastic.
Okay, the middle stent and the step down. We expect that.
Yeah.
That middle area looks kind of crappy, so we might have to interrogate that and decide. Unlikely we're going to do anything, but I think that's going to be a problem. Should we just put a short stent? Maybe, right?
Yeah.
All right, we'll decide that. But anyway, so Raman will sign off. Time's up. Thank you again for signing in from outside. And we'll see you guys next month. Raman, next month, July 31st is the live case.
Perfect. All righty, guys. Well, PK, Vishal, David, Ray, thank you all for taking care of showing all this really, it's, I wouldn't say straightforward, but very educational case with, showing and demonstrating all of our different therapeutic options and, treatment algorithms. And again, thank you for joining us today again from Mount Sinai Hospital. And we look forward to having you on July 31st next month to kick off the academic year. All right. Thank you again.